Good morning. Dwayne Spencer again, President and CEO of Habitat for Humanity of Greater Memphis. Welcome back to our Health and Housing Summit webinar series. Happy to see you all here. I want to start off by thanking our sponsors once again who helped make this event possible. The Tennessee the Tennessee Housing Development Agency, Wells Fargo, and Methodist Bonheur Healthcare. And thanks to our advisory group once again. Believe it or not, we're now in week 3. And this week, we have 3 incredible sessions planned for you. We've gone from the national perspective to age-friendly efforts in specific states. And I'm really excited as we turn to some industry-specific panels. So today we're going to dig into the healthcare perspective. As I continue to say, we at Habitat are housing practitioners. We know about construction and the necessary interventions to improve our seniors' homes. We aren't healthcare providers, but we're learning how our interventions have a positive impact on the health and well-being of our clients. So now we want to learn from experts about what drives decisions for hospitals, health systems, and payers. What motivates them? And what their value propositions are, as we hope to form valuable partnerships and alliances going forward. So just a few quick reminders for all of you. Continue to use the chat, say hello. And then if you have a question, use the Q&A function, and we'll send those out to the panel for you. And then also feel free to tweet and post about the event. If you do, then please use the hashtag TN Health Housing Summit, or just Memphis Habitat. So today's moderator is Robyn Stone, Doctor of Public Health and Senior Vice President for Research of LeadingAge and Co-Director of the LeadingAge LTSS Center at UMass Boston. Dr. Stone has 40 years of experience as a researcher and policymaker in long-term care and aging services. She spearheaded the LTSS Center's major applied research initiatives in several areas, which include identifying and testing models that link affordable senior housing with health-related and supportive services to allow residents to age in place and developing a quality aging services workforce. Dr. Stone also serves as a bridge between the research and policy and practice communities at the federal, state, and local levels. Dr. Stone, I'll turn it over to you. Thank you.
Thank you so much, Dwayne, and hello, everybody. Good morning. I think it's good morning for everyone. I was actually expecting primarily a Memphis audience, and it looks like we've got people from all over the country, so that's fantastic. As Dwayne was saying, my organization, LeadingAge, is a nonprofit association of over 5,000 aging services providers. And a lot of them actually are housing providers. We have over a third of our membership are affordable senior housing developers and managers. And they have been focused for many, many years, certainly for as long as I've been at LeadingAge, which is now going on over 20 years, really have been focused on how do we help lower income older adults age successfully in the community, and have really highlighted the importance of that intersection between health and housing, which this panel is going to do today. I'm really excited about you all to hear from our 3 presenters. It's really great to think about the national landscape and also to try to understand what states can do. But at the end of the day, it is where the rubber hits the road at the local level where these initiatives are actually going to happen and play out. Whether it is helping people to remain in their own homes, whether it's actually providing other kinds of options that link housing and health together for people who can no longer remain in their own homes. And ultimately, the big challenge for us is going to try to figure out how do we make these fantastic pilots and examples more normative within our communities and across the country. How do we make them sustainable? And so today we're going to talk about that with 3 fabulous presenters. I've been on the Zoom with them a number of times, and we've got just a great array of folks. We're going to start with Terry Rappuhn, who I think really exemplifies here what we're talking about. She has a history as a hospital systems CFO, but in her past few years has created a construction company to actually help aging buildings, aging housing for older adults to actually reform, retrofit, and address the physical and environmental issues that older adults face in terms of being able to successfully remain in their homes. So Terry is that sort of on the ground intersection between understanding health systems, understanding construction, and then being able to really put those two together and to talk the language between the two worlds. And I think that's a really important point here. Second, we have Dr. Kiffany Peggs, who is the medical director for long-term services and supports at United Health Group. And Dr. Peggs is really going to talk about all of the initiatives that United Health has been involved with. LeadingAge, we have actually been involved at the federal and the state level with United Health, and we know all of the different kinds of activities that they are engaged in. And so we're really excited to hear from her. And then finally, we're going to hear from Dr. Albert Mosley, who's the Senior Vice President and Chief Mission Integration Officer at Methodist Bonheur Hospital, and just had a fabulous conversation with him today about how he's actually addressing some of the challenges in the vaccine rollout in his community. There's so many issues that need to be addressed in terms of linking our older adult population with health, social supports, and obviously the important piece here, which is housing, both as shelter and as a platform for actually linking housing with health and long-term services and supports. So with that as an intro, everybody's going to do about a 5-minute presentation. Then we're going to follow up with a lot of Q&A. We want as much interaction from you all as possible. So without further ado, I'm going to turn it over to Terry.
Thank you, Dr. Stone. Today, I'm going to be speaking primarily to the intersection of healthcare and older adults living in single-family homes. Westminster Home Connection repairs and makes mobility modifications to empower older adults and persons with disabilities to age in place safely. And I'm a founder and still active at Westminster. We built this organization by really taking one step at a time, figuring out what makes sense, and then just taking the next logical step. Our model has 3 components, and I call it the 3-legged stool. We have a referral base, which is how we connect with the person. We have operational capacity, which is the infrastructure and ability to do the construction work. And then we have funding, which is the financial resources to pay for the work. Now, Keith Branson in an earlier session described Westminster Home Connection from the perspective of solving housing challenges and serving older adults' housing needs. And since our session today is the health session, I'm going to focus on the healthcare aspect of housing. There's a tremendous return on equity for older adults to be able to age in place at home. And of course, that's what most people want to do. So why doesn't it happen more often? Well, it's fundamentally because that's not what we pay for. Our systems of healthcare don't pay for aging in place. It pays for healthcare when people fall, or Medicaid pays for nursing homes when people can't perform their activities of daily living, bathing, being able to use the bathroom. So who financially benefits from aging in place? Of course, besides the person who benefits the most, but it's who's ever paying for healthcare. And most of the money comes from insurers, Medicare and Medicaid. Ultimately, behind the insurance company is primarily the employer, and behind Medicare and Medicaid is the government. So the payers are financially incented to keep people safely in their homes, and then they don't have to pay for the ER visits for falls or nursing homes for people who can't do their activities of daily living. So as Robyn said, I'm a health systems operator and CFO by background, and by health systems, I mean mostly hospitals, but also the entire continuum of care to include inpatient, outpatient, physicians, post-acute, which is home care, skilled nursing, hospice, and DME or durable medical equipment. And in that role as CFO, I spent a lot of time on healthcare payment approaches incentives, and contracts. And then earlier in my career at EY, I audited captive insurance companies and worked with actuaries and underwriters. So that's going to be my perspective. And I know that there's more than enough money already spent in healthcare to pay for the housing modifications that are really needed to empower older adults to age in place safely. You know, this is not going to be a revelation to most of you. Insurers understand this. The government understands it. And there are many programs and efforts to make repairs and mobility modifications and keep people in their homes. An accountable care organization is a group of doctors and hospitals that come together to coordinate quality patient care, and they get bonuses when they do that at a lower cost. Medicaid in some states, some insurers have programs for value-based care. And there are value-based care arrangements throughout the healthcare system that involves payers of all kinds and healthcare providers. I'm going to have to say, with spotty success. Not that the programs themselves aren't successful individually, but there aren't many housing programs within healthcare compared to the opportunity to benefit both the person, but while even spending less, not more overall. So that's going to wrap up my first point. Our financial incentives are misaligned, and today, in most cases, it's the payer, not the hospital or the doctor, who is the critical place where business and financial incentives come together. So you may say, well, Terry, why didn't you build Westminster Home Connection as a part of and with dollars from healthcare? Because that's my world. Why is that? Well, intuitively, we knew that there was too much stuff involved and we would just never get off the ground. We've seen that recently in a big way with the breakup of the Haven joint venture between Amazon, Berkshire Hathaway, and JP Morgan. And you know what? I was really rooting for them. I was as excited about that JV as anything I've seen in healthcare for a while, because their objective was right on point to transform healthcare. But in the end, it was just too unwieldy. So they've broken it up and they're going after important but smaller and more manageable goals. So in our little way, as we built Westminster Home Connection, I myself have been looking for a way to become a part of the healthcare ecosystem. Today, we get about half of our referrals from healthcare sources, home care, case managers from insurance companies. We get a little from hospitals or rehab discharge planners. So we are a key part of the healthcare system at the ground level. I call it the real world. But you know what? We're not really on the radar screen in the healthcare world where decisions are made. I've had a few conversations at the executive level and everybody gets it. I really think at some point in the future, we're going to get there. But I myself cannot figure out how to do it in a big way. I kind of feel like that bobcat that's laying in the weeds, watching, looking for opportunities, how to do it. And I know how things work on both the construction and the healthcare side, but I can't really figure out how to connect them. It does have to be, though, through combining both the models and the incentives. So by building Westminster Home Connection from the ground up to find the model that works in the real world, we started with just one construction supervisor, volunteers, and a goal to make repairs for older adults. We didn't have a lot of money, and we didn't really need a lot of money. This program that we are running can be started with a few volunteers building wheelchair ramps on weekends. You need a champion and a few dollars for materials. Today, our revenue is close to $1 million a year, and we work with 300 adults in 14 counties. So what are the keys? It has to be person-centered. The key question is, what does this person need to age in place safely at home? Focusing on the function of the home, not the cosmetics. And you have to have contractors who can focus on the person first. That's not what a contractor will normally do coming into a house. They're going to come into a house and see the house, not the person. When Westminster sees that someone can't take a bath, we cut a door or a side out of the bathtub and convert it into a step-in shower. We add a grab bar, an ADA shower head, and a shower chair. That's going to run about $1,300 versus the $5,000 to $8,000 that a contractor would have to charge to demo the bathtub and install a new shower. And by the way, they wouldn't put a shower chair in it either. When Westminster hires staff, we look for construction skills and compassion. And then when we find someone who has both, we have a job with purpose. So that's our secret sauce. We also have to have social work partners. Our preference is to take referrals from case managers because people who need repairs and mobility modifications also need other things that we as construction people don't do. Our funding comes from foundations, individuals, corporations, and churches. It's kind of ironic since the financial benefit goes to insurers, employers, and government. So how do you scale it? I think that our future is to combine our program with something like the capable program approach and incorporate fundings from insurers, employers, and government. We know specifically what construction work is needed to avoid unnecessary healthcare costs and age in place. We developed a coding structure for our services. And so for healthcare people on the session today, you're going to recognize this as something like coding for APCs or the ambulatory payment classifications, except our coding system isn't for payment. We developed it because we needed to understand the specific construction work that we were doing so that we could communicate it to our funders and show them the impact of their support. We have 7 major categories. We have plumbing, electrical, carpentry, which is doors, windows, cabinets, and structural work and floors. We have mobility, which is carpentry mobility and plumbing mobility. So 2 trades involved in mobility. We have HVAC, we have roofs, gutters, soffits, and fascia. And then we have sort, pack, move, which is not really construction. There's about 200 categories that we track as to what our services are as we go throughout the year, averaging about 6 services per home, but it can range from as few as 1 to as many as 25 because it's about what does the person need. To give you an idea of what we do, which is a proxy for what people are going to need to age in place safely, we've been in 1,500 homes at this point, so we really know what the categories are. About half of the homes need at least 1 plumbing repair. I swear, half the homes in Nashville have a leak. It's just amazing. In 2020, just to give you a snapshot of some of the different categories, we replaced or repaired 49 toilets, 35 bathroom sinks or faucets, 11 water heaters. We built or repaired 61 wheelchair ramps. We built or stabilized 93 sets of railings and 70 grab bars. Think about how important it is to hold on to something if you're unsteady on your feet. We put new roofs on 14 homes. We repaired gutters, downspouts, HVACs, doors, windows. We added GFCIs, which is a grounded electrical outlet for safety from water in kitchens and bathrooms, and that's what we do. It takes surprisingly little to make a home safe and functional for an older adult. Our total cost is about $3,000 per home, and avoiding 1 year of skilled nursing care for 1 person would be enough to pay for 30 homes. Think about avoiding 1 hip replacement from a fall. How many homes would that pay for? So there's definitely a return on investment for the healthcare payer. My concluding remarks is that in the intersection of health and housing, I think sometimes we start too big. In healthcare, we're one of the most regulated industries in the company, and we think about the risk. We can build some big programs with lots of requirements and costs. In government, there are a lot of other objectives that can get in the way. You got to have 3 bids. You got to look at weatherization. You got to get a lien to pay it back if they sell the house. We could spend $20,000 or $30,000 in many of our homes, and it would be good to do. But the key to making the repairs and mobility modifications to age in place is knowing when to stop. So in my vision of aging in place, the quarterback is the older adult and their family, supported by healthcare clinicians to help them understand their options and what's possible. Then supported by a construction team with the discipline to do enough on the house, but not too much, because they understand that the function is focused on what's best for the person. And when we find a way to combine health and housing, my hope is that we can stay focused on the objective, which is aging in place.
That was fantastic, Terry. And now from another perspective, from an insurer perspective, I'm going to turn it over to Dr. Peggs.
The most important thing that I am starting off as a geriatrician. When I became a geriatrician over a decade ago, most people didn't know what a geriatrician was. So what I do is it's a specialty that looks at the holistic care of the older adult. And I think it speaks to a lot of the things that people are trying to do from both a healthcare perspective on this call, as well as the housing perspective. Our goals are really healthy aging and aging in place. Aging in place, probably the most key to the conversation today. And I'm a geriatrician no matter what I do. I'm a geriatrician when I'm working in equity. I'm a geriatrician when I am I'm a geriatrician when I am working at UHC. I'm a geriatrician when I'm seeing my patients. So the focus is always about healthy aging in place, and keeping that that person's personal goals in mind. So it's not just about what you would want or what you think is the right thing to do, but it's really about what that person wants and what their priorities are. And as many of us can guess, and what also Terry just said, most people's goals is aging in place and staying in that home. With UHC, I work for the Medicaid program, the Choices program. We do have embedded in that some funding set aside for what we call minor home modifications. And there's limitations to that program. Probably the most important one to point out is that I'm a doctor, not a carpenter. As Dwayne said, he's a carpenter, not a doctor. So part of the limitation of the program is how it's set up through Medicaid, is that you have a physician and a group of nurses who are also not carpenters or contractors or anything else, looking at a request and trying to make a medical necessity or just even an opinion on, is this the best thing for that person in their home, lacking the expertise on the function that it's going to bring and or the person's needs as a whole. So it really does lack that perspective from a construction meets healthcare needs and stabilization standpoint. But the other limitation that has already kind of been touched on a little bit is just all of the limitations around what can and can't be done, those rules that are set by CMS and then have to then form the program. Terry had talked about some of the things around bidding and around what's offered, ADA compliance, which is important, but sometimes impossible to meet someone's needs and keep them in the home appropriately at the same time. So it really makes that job more difficult and really outside of what I could ever do, and also around outside of what the program, the minor home mod program, can do. So we do things to get around this. We have come up with numerous partnerships throughout the state. And I have people on my list to also, again, probably after this conference is over, to also reach out to, so that we can meet those people's needs outside of what that benefit covers. In addition to meeting those needs for people outside of the benefit using excessive resources, I have a great member advocacy program. The director, Melanie Lamb, has found other options using state grants to look at foundation repairs for housing, looking at grants around the state for meeting people's needs to get them back into the home, especially trying to move back in the community, and their current house needs significant remodeling outside of the benefit to help meet those needs. And it's been, we've had a lot of success stories from this, but there's still a lot of more work to be done. The other thing I want to point out that we're all working on is trying to meet people's needs around just housing in general. We had opened up some temporary housing. It feels like forever ago because of COVID. I believe it was the end of 2019 where we started opening up temporary housing for those who are within any part of the population, whether their choices or not. And we had some people use that transitional housing that were elderly, making a particularly one lady who had unfortunately had her house burned down. She had nowhere to go. And they were able to use that transitional housing that is ADA compliant, that lets her get in and out, have her own independent space. And then she was able to then transition to another housing. So we're trying to open up those options around the state as well, but then also partnering to keep people in their homes, because from a geriatric standpoint, I know, and I think everyone else here believes and knows as well, that keeping someone safe in the home is some of the best medicine there is. So having someone that doesn't have unnecessary steps in the home to have to try to navigate, and they will decrease their fall risk if they're already a fall risk. Simple things you can do in the home around just moving rugs are easy, but harder things are if you're wheelchair dependent and you have one of those older 1900s or early 1900s homes and you have a very narrow doorways. They can't use their appropriate walker or wheelchair because they can't get it through the door. So they'll be using inappropriate devices or not using them at all, just to be able to stay in their home and navigate it. So we're always trying our best to come up with the most innovative ways to keep people in the home, even if it means us going around the benefit and just paying for out of pocket ourselves, because it's something that we're just dedicated to doing. And that's one of the big, I think, harpers for me entering this program was that, we have the opportunity for people to age in place safely. So we need to be using it to the best of our knowledge and abilities.
Thank you, Kiffany. And let's turn now to Dr. Mosley.
Thank you, Dr. Stone, and thank you, Terry and Kiffany. Dr. Peggs, for your introductory remarks. For those who are joining us today, you're getting really, I think, some very rich perspectives about this topic. So Terry has talked with us specifically about her experiences as a hospital operator, and also her experience now being directly involved in providing options for seniors to age in place, to age at home. And then Dr. Peggs herself, as a physician, has shared with us from her perspective, working for UnitedHealthcare, and also her perspective as a physician. And so I'm going to talk very briefly about really the role of hospitals and health systems themselves in ensuring that seniors are, have really good health outcomes. And I want to do probably 3 or 4 things here as a part of these sort of introductory remarks we've each been making. I want to first give you some sense of who we are as a health system. So provide you with a bit of an introduction about Methodist UnitedHealthcare, realizing that not everyone not everyone in the session today is from Memphis or from Tennessee. Then I want to talk also briefly about sort of our market, what the market looks like here, because oftentimes, we don't take into account how significant various socioeconomic factors about a market actually impacts the work that we do. And then finally, I'll talk very briefly about my role here in this health system. So for beginners, for Methodist UnitedHealthcare, we are a 6-hospital, not-for-profit comprehensive health system located here in Memphis. Our system has a total of 1,665 licensed beds. And for the calendar year 2019, and I'm using 2019 as kind of the base year because 2020 was, as we all know, a very exceptional year for everyone. But for 2019, we had over 67,000 discharges from our hospital. So discharges means inpatient discharges. So we had 67,000 folks who were inpatients and discharged from our facilities, and close to 380,000 ED visits as a system. Now we are here in this market, we're the 2nd largest not-for-profit employer in Memphis, employing over 13,000 associates who work alongside our 2,500 physician partners. Additionally, our health system has roughly 100 primary care settings, surgery centers, and diagnostic centers, a good number of which are located in sections of the city and sections of the market where we are actually the only healthcare provider. Now, in terms of patient experience, system-wide, and this is one of the things that I like to share with audiences because I think it's meaningful, especially for the topic we're discussing today. We scored system-wide in what we call the top box. So that means a 9 or a 10 on a scale of 1 through 10. We scored in the top box 85% of the time for patient experience. In fact, for our system, if a patient scores us anything less than a 9 or a 10, we actually consider it to be a 0. So what that means for us is that we want to ensure that patients have the very best experience, and we challenge ourselves and push ourselves to ensure that whenever our patients encounter our providers or encounter our healthcare workers, that it is a very pleasant experience. I want to talk just a little bit about quality and safety metrics, still sort of introducing our health system to those who may not be familiar with us. In 2019, we achieved what we call top quartile or above 71% of the time. And so why is this important? Well, it's important to us, and it's important to, I think, everyone on this panel today, because we know that patient safety and clinical quality are top priorities. And for us, we've seen our quality and safety scores rise rather significantly across all metrics in the past few years. And we're very proud of that. And because of those improvements in patient quality and safety metrics, our system as a whole has earned an A from Leapfrog. And for those who may not be aware, Leapfrog is our industry watchdog. And you can check grades for hospitals and health systems across the country on Leapfrog. We've earned an A because of our emphasis and our improvements in patient safety and patient quality. Most recently, in addition to this, the A that we earned from Leapfrog, our system earned the coveted ISO certification. It's an international certification, and it's yet another indication of our commitment to ensuring that all of our patients receive the very best quality care. I'll tell you also that we are the largest provider of TennCare, the state's Medicaid program in the state of Tennessee, Methodist Bonheur Healthcare. We served over 270,000 TennCare patients in 2018, and annually, on average, on an annual basis, we serve about 270 to 75,000 TennCare patients. In terms of health and well-being beyond the walls of our hospitals, our community outreach division, which is a very large division within our system, we're kind of unique in the sense that we have an entire division with about 300 full-time employees who devote their time and their energy and efforts to working with people within our local community here. But that division is comprised, the community outreach division is comprised of 25 plus evidence-based and best practice programs that are designed to meet the needs of our community. And so some of these programs include things like Healthy Families America, the Nurse Family Partnership, and perhaps more germane to this conversation today, it includes also the Capable program, which, as you know, focuses on seniors who are being discharged from the hospital who are at high risk for falling, but who do not require or receive home health services. Now, unfortunately, the Capable program is sort of on hold right now because of COVID, but certainly when we move beyond this period of time, we will resume those activities through the Capable program. Now, let me share with you just a little bit about our market. Again, I think that's important for you to know because it also speaks to, as I said, the type of work that we do and how we position ourselves to do that work. And so, when I describe our market here and I talk about some of the socioeconomic conditions that really influence the way we do our work, I found it best to turn to sort of a literary reference to do that. And so the literary reference that I use often is Charles Dickens' A Tale of Two Cities. And if you'll remember that from high school or wherever you may have read it, Dickens writes about the spring of hope, and he writes also about the winter of despair. So he talks about these two sort of opposite visions. And so Memphis could in many ways be described as being in its spring of hope. And one of the reasons I think we can be described that way is because we can boast of an extensive list of attributes. For example, we're home to 3 Fortune 500 companies. So we've got FedEx here in Memphis, we've got International Paper, and we've got AutoZone in Memphis. We've also been consistently ranked and rated as the #3 most charitable city in the nation, with 90% of our population here in our city donating money to some sort of charitable and or nonprofit organization. So that's our spring of hope. That's the positive good side of it. We also, unfortunately, we have this winter of despair as a part of our market. And what I mean by that is we are the #1 poorest among metropolitan statistical areas, MSAs, with the poverty rate hovering slightly above 25%. So just a little bit over a quarter of our citizens live at or below the federal poverty level. And we know, of course, that a good number of our seniors also live in poverty. We've been ranked as the number 10 most unhealthy city, and that's graded across healthcare, food, fitness, and green space. In our market, the chasm between the rich and the poor, especially along racial lines, is particularly noticeable. So for non-Hispanic whites in our community, there's an overall poverty rate of slightly above 10%. For non-Hispanic Blacks in our community, there's a poverty rate just above 30%. So that's a very statistically significant difference between the two. Unfortunately, Memphis also has one of the highest crime rates in the nation, the number 4 highest violent crime rate in the United States, behind St. Louis, Detroit, and Baltimore. And this is largely due to the lack of socioeconomic opportunities that members of our community have. And so I shared that with you to kind of paint the picture for you and to help you to understand how the socioeconomic landscape here creates a number of challenges as it relates to providing quality care for our seniors, as it relates to ensuring that our seniors have adequate and appropriate housing as well, and that our seniors can certainly age in place. So, you know, in essence, we're sort of beginning with a deficit. You know, we're treating a patient population that is by and large poorer, that is sicker, and faced with greater socioeconomic challenges that we believe and know contribute to overall health. Interestingly, one of the interesting side notes about our market is that there is some growth in this market. There's population growth in this market. The growth in our market is limited specifically to our senior population. And so, you know, a lot of markets around the country are shrinking and dwindling. There's growth in Memphis, and the growth is occurring primarily with baby boomers and the senior population. So let me wrap up by just saying a little bit about my role in our health system and what I do. I serve as our Senior Vice President and Chief Mission Integration Officer. I basically provide strategic oversight of our system's foundation. The foundation is responsible for fundraising, for service line development, capital projects, program expansion. I'm also responsible for our behavioral health service line, and we do know that we see a number of seniors who are, who unfortunately have to use behavioral health services that we provide. I'm also responsible for our system's social determinants of health and all of our community health initiatives that we do as a health system.
Thank you. Thank you, Dr. Mosley. Thank you, all 3 panelists. I think you've gotten sort of a full array of perspectives from various health systems perspectives. Terry, the former CFO of hospital and health systems who has now gotten into construction and really makes the bridge, I think, at the local level between health and housing. Dr. Peggs, who is a geriatrician, to my mind. I wish every primary care and internist were trained in at least some geriatrics. Oftentimes the folks who touch older adults don't really know what that means, and good geriatric training is pretty critical. And having a geriatrician as a medical director of the LTSS part of UnitedHealthcare, I think is really important in terms of understanding not just the need for medical care, but the need for social supports and all of the social determinants of health, including the role of housing. And then finally, Dr. Mosley and his role at one of the large hospital systems in Memphis, and having the responsibility for really the community outreach, social determinants of health, and charitable fundraising, all of the things that are actually required to go beyond the bricks and mortar and the systems of health in our country. I want to talk a little bit and ask some questions of each of our panelists, and please send in your questions as well. We will try the best that we can to actually address all of them. But I wanted to start with Terry, and I wanted to ask you about operationalizing the cost savings of the financial benefit that supports the housing costs. You talked a little bit about it, but in your vision, how would you see really taking this from your small scale to a larger scale, thinking again about the role of UnitedHealthcare, the role of Bonheur hospital system, the partnerships between health and housing that could happen? How do you think about operationalizing the kind of program that you are engaged in?
Thank you, Dr. Stone. You know, I really think that it goes back to building your incentives and who's benefiting financially. Now, the patient's actually benefiting financially because they're going to have lower out-of-pocket costs, lower, other costs. But of our client base, they're almost all living on Social Security. So our criteria says less than 80% of average area median income, but reality is they're mostly living on Social Security. It's rare for us to have anyone that isn't. Our median household income per month is $1,500 a month, which is about Social Security. So really, you're going to come back to the payer, I think. Now, the hospital, by the way, can be the payer, but it's really about who's at risk financially for the services. And because it's difficult, in my experience, for the Medicare and Medicaid to move quickly, I'm going to say that I think our best chance is to work together between the payers and the providers of care. So if I could build it, I would start from the insurance company's perspective. And I'm assuming in my example, that this is an insurance company that has a risk-based insurance program. So you get paid per member per month. And that means that you're at risk for the healthcare, and you do better if your healthcare cost is lower, and you do worse if your healthcare cost is higher. That's a plain vanilla example. In the real world, it could be more complicated, but you could contract around the complications. So let's just use a very plain vanilla example. In that case, I would identify my members who are at risk for falls or not being able to handle the activities of daily living. And I won't call it the 80-20 rule. I'm going to call it the 95-5 rule to say who is at risk. And I believe Dr. Peggs would tell us that insurance companies know that. They already know that. They know who their members are, and they're already thinking about that. Then I would make an occupational therapist and a nurse available to my at-risk members. They would meet with each member to discuss the member's goals for aging in place in their home. What would improve their safety and functionality? The clinical team would then forward the mobility modifications and repairs to Westminster. Now, you may think that I'm describing capable, but here's where I would diverge a bit. Because what we've learned at Westminster is we can't just do repairs and we can't just do mobility modifications. It's a holistic package. And so Westminster then would go on site and do a site assessment at the home. Like Dr. Pegg said, she's not a construction person, we're not clinicians. But what happens when we get called in, and we get called in by a case manager from a home care agency, say, we're called in for 2 services. We're called in because there's no railing or there's, something, they can't get through the door, like you were saying, they can't get through the door, we need to widen the door in the bathroom. We'll find 6 more critical repair needs. And if the person owns the home, then we will make those critical repairs. A need for a grab bar will turn into the kitchen overhead light doesn't work, or the floor in the bathroom is spongy from some long neglected leak, and so on and so on. So in my scenario, a construction team like Westminster would make the modifications listed by the clinical team, as well as the critical repairs identified in the construction assessment. And then again, I'm coming back to a capable model. The occupational therapist and the nurse would return to ensure that the older adult can use the modification and assess where the person is in comparison to their goals. The cost of this program, and we've done this for years now, and it runs the same number within a couple $100 every year. The cost of this program would average about $3,000 for the construction. So it is higher than capable because we're doing more, we're doing the repairs, plus the cost of the occupational therapist and the nurse. And I'm confident that over time, a risk-based insurance company would save more than the cost. But the real value, of course, is going to be to that older adult and her family because she's able to stay in her community.
Fantastic. Before I go to anybody else, and actually I have a few questions of my own, do any of you want to respond to Terry, Dr. Peggs, Albert, anybody? Or you want me to go on with some other questions?
I'll just add that now this is just like my rough sort of estimate on things, and I'm always faced with that rising cost of non-skilled services versus the increasing cost and how much they're using overall. And what I've seen since I've been in charge of this program, going, it's like my 4th year now, is even though our HCBS and minor home mod costs have remained steady or slightly increased, putting in those supports has actually decreased the cost of care. It took a few years to get there, but you're right, Gary, you do see that correlation over time, that doing these things, and now of course there's a ton of other things at play here, but looking at this steady population, you are seeing that slight decrease in utilization of inpatient care.
So,
And I'll just add very briefly, Terry's scenario that she described. I mean, it's certainly. I don't want to. Well, it would be the ideal situation. It really would be, both for the patient, the senior, and also I think for I can't speak for payers, but I'm assuming Dr. Peggs for payers, and certainly for providers also. So it, Terry, what you've described provides for all of us, I think, a challenge of where we should be going when it comes to providing care for our seniors.
Dr. Mosley, I think what you're saying, it reminds me of something that we did in the industry a while back. Many years ago, I was on something that was led by HFMA, which is Hospital Financial Management Association. It was called Patient-Friendly Billing, and it was the early efforts to get patient engagement before we used to use those words. And what we would do is we would bring all these hospital CFOs and revenue cycle leaders into a room, and we would, from across the country, and we would try to solve a really difficult problem. And the thing we would do as healthcare people is we would talk about all the reasons, all the problems in doing that. And what we decided to start with instead of that was the vision. What is our vision for the patient experience of the future? And once people could visualize, then they could get excited and they could start talking about, oh yeah. And then somebody would say, well, you can't do that. And then somebody else would say, well, we are doing that. And then it was such a rewarding experience by visualizing what we want and then finding ways to break down those barriers.
Absolutely. Yeah.
We have a few very specific questions around construction for Terry, but before I move to that, I wanted to spend a little bit more time talking really about the health housing partnerships. As I mentioned at the beginning, LeadingAge is a large organization with many housing providers. We're not providing private homes. We actually are developers and managers of affordable senior housing. And one of the values of having affordable senior housing is that you get tremendous economies of scale. So you have perhaps hundreds of people living in a building or a set of buildings where you have enough volume of people who are at risk, where you actually can attract the insurers because they find that those folks are actually going to be able to reap the benefits. It's hard when you have somebody living in the community who is living in their own home. You have to have enough people in those situations to actually get you your return on investment. And so I wanted to sort of ask you, Terry, Dr. Peggs, and Albert, a question about the partnership between health and housing, and how do we think about that in terms of the volume that is needed to actually encourage the insurers and the payers to be a strong partner in addressing the housing needs, which ultimately, as a public health person, we understand if we address those housing needs, then we can address function, we improve health and quality of life, we can potentially save money on hospitalizations and emergency department use, and even movements to nursing homes, which we know for many lower income older adults is the only option because there's not much residential option out there for people other than to go to a Medicaid funded nursing home. So the question that I have for all of you has to do with how do we create the scale, which means partly we have to have enough volume. Terry, do you see enough volume in the number of homes that you're doing to actually attract an insurer or a group of insurers? And coming from the insurer or the hospital side, what do you need in terms of the size of the population to actually make these programs work?
Well, I'll go first. I think that you're hitting on the crux of the issue here of really operationalizing this because, yeah, we're in 250 homes a year, but the payers are sprinkled all over, everywhere. And so, it's not like I've got one payer that we can go to and cut an arrangement with. So I think it has to start at the payer level if you really want to use the savings to pay for the work. And so that means you've got to do some kind of you've got to have a program, you've got to have a specific type of policy, you've got to have an accountable care organization so that you have lives attached to the savings. I mean, I think practically, I don't know. I'd love to find a way to do it.
I would add, Dr. Stone, that part of the challenge, I think, for hospitals and health systems is really the reluctance to wade into this particular space. So hospitals and health systems, we are having tons of conversations about social determinants of health. And we're having tons of conversations about developing and designing interventions to address these social determinants of health. The challenge for us is that for so very long, we have expended the overwhelming majority of our resources addressing that, what we know now to be just that sort of 20% of your, the biochemical, physical aspects of health. And the other 80%, these non-medical factors are the ones that really impact an individual's overall health. A lot of hospitals and health systems, they're comfortable, when you talk about social determinants of health, I mean, they're, depending upon which tool you're using, there could be up to 25 to 30 domains in the tool. A lot of hospitals and health systems, they're comfortable looking at food insecurity. They may be comfortable talking about personal safety, but when it comes to housing, many are very uncomfortable to sort of engage in that conversation because it involves something that we've just never done before. There are a few examples around the country, one or two that I can think of, where health systems have begun the process of providing, or at least they've not providing, but they've begun the process of either building or partnering with someone else to provide affordable housing solutions for members of the community. But I'll tell you just sort of candidly and up front that it's going to be it's really difficult to get health systems there. And a lot of it is because of all of there are so many regulations that we ourselves are hindered by. But also, I do think, and I certainly appreciate that there is a growing awareness among providers that housing plays a significant role in the overall health outcomes of our patients, and most especially for seniors.
I just want to add something really quick. I think those are all fantastic points and probably said better than I ever could have said it myself. But I think there's something else to consider in this conversation is time and looking at the right populations for projects like this, and also the right supports, additional supports are going to be in place other than just providing the housing. I say time because when I gave that example earlier about, I did a bigger look back over a 3-4 year period and saw a decrease in total expenditure. We're often in the boardroom, we're looking at quarter to quarter, and you're not going to see these changes quarter to quarter. So you have to have when you do an initiative like a housing initiative for the elderly, you'd have to say, okay, and then that's a problem with every geriatric model I can think of, is it takes time to see those results that they're going to want in 2 quarters from now. So setting that expectation that we're doing this long term so that we can see all of these benefits that we know will come from these initiatives. That's only I wanted to make sure that it's very much appreciated on my side of things.
Yeah, no, I think your points are all so well taken, and the candid conversation here is so important. As someone who's been in this for a very long time, trying to figure out how we link housing and health and all of the social determinants of health, the barriers are tremendous. And I hope that the people who are listening to this, who are coming from the healthcare side and the housing side, understand that there is will among many, but the challenges are great. That's not to say that we can't get there. one of my questions has to do with who's responsible for what, because it certainly, if you're looking to support an OT, an occupational therapist, and a nurse in a community that could actually really help with understanding, assessing, and then helping older adults to actually achieve greater function, and somehow the construction rehab dollars could come from another pot that are put together. I mean, I wonder how many folks in the audience come from the housing world. Where does housing policy fit with health policy? I do not believe, quite honestly, that we can put all of this on the shoulders of insurers, health insurers, or hospital systems. Quite honestly, they have enough trouble dealing with the medical care. On the other hand, the implications of having a model that actually links housing with health. In our own work, we have found that affordable housing with a service coordinator wellness team linked with accountable care organizations, this is in the state of Vermont with 140 housing properties, we were able to save substantial or reduce the growth in the Medicare program substantially. That's big savings for the Medicare program. And so how do we bring that back into the system to help people stay out of high risk, high cost care systems? At the same time, where is that money for construction and other things that are needed on the rehab, retrofitting, and I would argue even sometimes the rent piece of this? Where does that have to come from? And how do we think about the partnerships between housing policy and health and long-term services and supports policy? So I just wanted to throw that out there because I think you all from the health system, it's very difficult to put all that responsibility on you. On the other hand, if there are really benefits to be accrued, how do we strengthen these partnerships, particularly at the local level or at the state level, to actually make this happen and maybe bring some new funding into the streams?
Dr. Stone, I'll just add one point here. I think it certainly will require a different and new level of creativity and innovation. And to your point, it's going to require some partnerships that we probably would not normally think would go together. So I'll give you an example. At the other end of the spectrum, on the pediatric side, we developed here in our system a few years back what we call the medical legal partnership. And so as a health system, we've hired a full-time attorney who works specifically with parents of some of our pediatric patients who find themselves in substandard housing situations. And this attorney, who's employed by us full-time, he ends up taking landlords to court and doing the types of things that need to be done to ensure that the housing environment is appropriate for children. So, the challenge for us as a health system, so we've got that model, how we're doing that with our pediatric patients. How then do we do that at the other end of the spectrum with our senior patients? How do we develop that type of program? And it's, it sounds easy, but I'll tell you, it took us quite some time to even get in place the medical legal partnership on the pediatric side. But it will. But to your point, all of these things will require a new and different level of innovation. It will require us to think outside the box, to do things we haven't done before, and to really partner with and collaborate with community agencies and others that we may not traditionally partner with.
That is a really good example, and that actually brings me back to Terry to ask about some of the life safety issues in housing itself. One of the questions has to do with, do you have issues with not bringing the house into life safety and building code? How do you sort of deal with the housing regulatory side, which on the legal side, you're actually trying to get people access to better housing so that it's not substandard. Sometimes it's the fault of the landlord. Sometimes it may be some more structural challenges. On your end, Terry, how do you deal with these life safety code issues when you're going in to do a retrofit? And then I would say, how do we think about a partnership where there's a win-win for everybody so that we don't actually need as much legal help as we do right now, which is that there are systemic changes that happen that bring substandard housing not only up to code, but up to actually the modifications that are required to help older adults age successfully in the community. So Terry, there have been a number of, there must be some construction people on the line here who are really interested in the ins and outs of how do you deal with all the regulations and issues on the housing side.
Well, you know, you're really hitting the crux of the issue. So our objective is to make the house functional for the person living in it. It is not the house, and it is not to bring the house up to codes. And if we do that, and there are programs that do that, there's federal home grant, you know, you're talking $30,000 or $40,000 a home, and that's a great thing, right? But we work in 250 homes a year, and we spend $3,000 a home. So clearly we're not bringing them up to codes. So, and then the real world of the seniors that we work with, the older adults who have lived in their house their whole life, maybe 35 years. A house might be 60, 70, 80 years old. The foundation might be on stacked stone instead of having an actual foundation like we would say today. We are not going to go in there and take the floors. And also, by the way, the crawl space is going to be 18 inches. And we're not going to go in there and take the floors up and rebuild the foundation. And that's an extreme example. We struggle with it. And it makes it hard for us to use federal grants, to tell you the truth, because we know when we have to cry uncle. So we aren't required to meet the housing codes because we aren't doing that level of work. We're coming in and doing repair work. Now, if we do something, we do it according to code, right? So if we have to do something and it requires a licensed plumber, then we get a plumber, they pull the permit, we put an HVAC in, we use a licensed HVAC company, they pull a permit, roofs, etc. But honestly, almost all of our work, I would say 90% of our homes we do with our own staff. And that's good in a couple of ways. One, it's a whole lot cheaper. We control their schedules. We get in and out. And we have, over time, we have about, I guess we have 6 construction staff now. They've developed specialties. So they can all do everything, but we have one guy who will get up and, you know, put the shingles back on if there's some shingles that are loose, or put some flashing down. We have one guy that does most of the plumbing kind of repairs. You don't need a licensed plumber to fix a leak, right, or snake a drain. We comply with the codes and the licensing as required, but most of what we do, it doesn't take a licensed person. If we have a house that has a plumbing leak, we don't have to hire a plumber. We send Wayne out and Wayne fixes it.
One additional question about your program, Terry. Do you have income parameters in terms of who you serve?
Yes, and that comes from our grants. So we just always say that we work with people that are under 80% of, you know, median income. Reality is most of our people are at the low or very low level of income. It's never a problem that we have somebody with too much income. And if there is, then you know what, we may do it outside of our grants. We do find occasionally, you know, a 95-year-old lady who's got the money to pay for whatever she needs, but she can't get it done. She doesn't have the ability she doesn't know who to trust. That's very rare though. Almost all of our people are, you know, living on Social Security.
What about the block grant in Tennessee? And how could you think about using that, or what's the impact of that for the health of older adults? And do you have any thoughts about that?
I can take this one. There's a lot of unknowns about the block grant. There was a statement that came out, I'm not going to give the right dates, I'm not going to try, that came out from the governor's office that TennCare as it stands right now will remain, at least for the short term, as is. But as some of you know, and a lot of you would probably feel it, the legislature, the Tennessee legislature, has a lot of say-so over TennCare within the CMS guidelines. And what the block grant does is remove some of those CMS oversights from Tennessee's use of Medicaid dollars. So potentially there could be some changes going on. Now, there's still a lot to be said about, will this block grant stand as is, the test of time, considering the circumstances in which it was approved and the timeline it was approved and the time it was given. So those that could always change as well. But I think for now, we don't expect a lot of changes. But that being said, you know, RFP for the is coming up. So there will be changes. We all expect on the MCO side of things. That's when we all bid for another contract with Medicaid. And there's also changes happening in IDD. So I expect there to be some changes coming through the pipe sooner or later. I haven't heard of anything specifically around the geriatric population or the high needs population. But I have already anticipate changes around IDD, which I'm also involved in too. So I can't tell you very much other than I'm waiting, as you all are, to hear what's going to come.
And the IDD is intellectual and developmental disabilities, correct?
Yes, ma'am. Sorry.
Okay. And Albert, I don't know, you were shaking your head. Do you have any thoughts about this as well, or?
I think Dr. Peggs has wonderfully stated that everybody is sort of, let's see, we are all in a suspended state now, really waiting to see what will happen. I think, you know, I will add though that I believe there's an air of excitement, particularly around, I go back to a point I made earlier, around the ability and maybe even the demand to be more innovative with the use of the dollars that we will have access to. So in our system here, you know, there are some people who are excited about the block grant because of there are folks who are thinking that we can do some things, you know, as I said, outside the box or whatever. But there's just so many unknowns right now, and so many of us are waiting to get a better sense of how this will roll out exactly and what it will mean for hospitals and health systems in particular.
Right. So at the same time that the block grant might provide a lot more flexibility, and I'm thinking here about whether there might be more potential to use some of these dollars. I mean, Terry, you talked about the ACO model, but quite honestly, in the theoretical world, a block grant that is flexible really provides an opportunity to do things that you couldn't do in a more restricted environment. On the other hand, a block grant also often, as we know, leads to cuts and less services going to people. So it's this sort of uncertainty around that you know, I was going to ask you the question of in President Biden's economic plan, he has a lot of money now, whether this is even going to be pursued, given the fact that we've got COVID right in our midst at this moment. But there is a lot of language around expanding home and community-based services and even providing a higher FMAP for Medicaid for states that actually expand on the HCBS side. And I'm wondering whether you all have any thoughts about how housing could be built into a larger home and community-based services infrastructure. Again, you know, if you think about what is important for older adults to live in the community, when you talk about home and community-based services, they need services and they need shelter. They need adequate, appropriate shelter. Those two things together allow them to live in the community. So, you know, how do we think creatively about doing this at the local level? I think despite all of the challenges that we face at the federal and state level through both the regulatory processes as well as the payer end of this, you know, what would happen if we had 1,000 Terrys in Tennessee, you know, with teams that you know, included an OT, a nurse, maybe you don't need a nurse, maybe you use a community health worker and an OT with a nurse that supervises over a group of people. So you get economies of scale and you can delegate, have a cheaper model. Maybe we build that together with construction teams that create new jobs in communities. I mean, I'm just sort of throwing this out. You know, could we envision Memphis or Nashville or whatever as a community model for really where the rubber hits the road, bringing all these folks together? And is there a role for public demonstration authority, as well as maybe philanthropy, to help us think more broadly about how we do this. That's sort of my wish list. I don't know whether you all have thoughts, and you're shaking your head.
Yeah, we've talked about a lot of the issues you brought up. Because really, I mean, there is that CLS model and that's covered under Medicaid right now, that community living supports, but because of all of the restrictions involved and the cost to the provider, it's still very limited. And it's not just, I didn't bring this up earlier, there's two big things. Terry touched on one, I think Dr. Mosley did as well, that you know, the people that we're serving, the elderly population, most of them live at or near the poverty line, but also Tennessee is a very rural state. So we also struggle a lot with getting housing in the outlying areas. I can't ignore that enough. I can't say that because I don't want to be ignored. But there are a lot of challenges, like you've mentioned, to, you know, how does that model look? How do we get them those supports they need in place? There's some restrictions around medications being given, nursing staff being available. So we've been having conversations with the state around what things we'd like to see changed in that current model. And maybe the block grant can open up these conversations even more now it's been passed, of we would like to see that CLS model change so that it could be expanded to meet the community's needs, while at the same time changing the supports that are in place so that they can do the things that are gaps in the care right now. And that won't take away, because I also do long-term care, I don't think that takes away from the long-term care population. If you've ever worked in long-term care, there's a list as long as your arm of people trying to get in. So it's just going to put the best patients or the best people in long-term care, and those who are more dependent in the community, instead of putting everyone in one box.
So yeah, I'd like to add to that. You know, one of the things, when you talk about rural issues and rural housing issues, so we're in not only Davidson County, which is Nashville, but some of the rural counties for the Tennessee people: Hickman, Scott, Morgan, Dyer, Lake, Obion County. So these are very rural counties for the most part. And the issues you have in the rural counties are things that the policymakers, I just don't think, it's not on the radar screen. People live in trailers. People live in sheds. I mean, people live in houses that a person, there's a big urban rural lack of understanding here. And so the kind of programs I'm afraid that we get built just won't even know that you can't go in and build everybody a new house. So there are things you can do that make a super huge impact. And if you put too many regulations and expectations around it, it just won't happen.
Yeah, I mean, I wanted to say that I just finished a little chapter on housing and rural aging America. And the worst situations for substandard housing are in rural elderly communities. These folks are much more likely to live in very old houses that are very substandard. And so the potential for investment in rural aging America actually is greater with these kinds of models, if we can figure out both the retrofitting side of it, and then how we link the medical and social services together with that. Obviously, we've got challenges of transportation and proximity and all of those things. But I do think that you're absolutely right. And Tennessee has a lot of rural areas. These are serious challenges. We're overrepresented with older adults in rural communities. So these are really hot spots. And if we could figure out how to bring this together, and maybe again, we're thinking about, maybe this is some job creation in some of these communities where younger people have left. If they have construction jobs that could actually help around this, it might be a way of thinking about some economic development and maybe bringing some unusual suspects into the discussion. We have looks like we got about 10 more minutes. Maybe what I would like to ask all of you, Terry, you've already given us your vision, but I'm wondering if we could get just sort of a vision, forget about all the challenges that we've just talked about. Maybe a vision coming from the geriatrician perspective, aside from the fact that I'm assuming you would want people to be more well-trained in at least the concepts of geriatrics. I'm a very strong supporter of geriatric training that is infused in all education of professionals who touch the lives of older adults. So from your perspective, what might a community model look like? And then going to Albert, also, what would be your perspective from sort of a large hospital health system in Memphis look like? And let's sort of throw that out in the few minutes that we have left, and we can see if we've got any other questions.
Sure, that's a tough question. And so, and I'm working on the education part, I promise. I think that I don't want to say that everything we have is broken, because I think that there are some good head starts that are in place throughout the state. My heart is always in Memphis. That's where my family still is. And that's where I grew up. But throughout the state, I think there's some decent starts. I think that there are, even in our best communities, there's a little bit of something lacking. There's a little bit of like missing icing and sprinkles on there that would make it more of a connected service. And I think that we've all kind of harped on who's going to pay for it to death today, but there's a benefit, I think, for everyone if we connected all those dots to make the things that are there work, and then take a big step back and look at what's keeping it from working better, whether that's a regulatory need, whether that's the population we're trying to serve. And I always try to keep my public health hat on as well to say, are we doing the right intervention for the right set of people? Because that's what I always harp on in everything I ever see, is that would work, but not for, the people who are in that particular even part of the state. And to make sure that it's really everything we're trying to do is person-centered, because you're going to have the best outcomes that way. But I wanted to say, if I had my magic dream would be is some sort of support for those in the community that either supported them as they were coming out of the hospital and doing the traditional care model as it was originally intended, to have all that built-in support there, so that make sure that people go out of the hospital and stay out of the hospital, and then they go into the community again, but they have that extra support there, whether it be skilled nursing in the home for them for a period of time to make sure they're getting all of their needs met, and then they gradually, instead of just stopping the care, they transition into another program that also meets their needs, whether that's just someone checking on them occasionally, whether that's somebody who's supporting them from a food standpoint. There's so many needs that are out there, even whether that's even like just getting them together so that you don't have so much social isolation, which is also probably, we came in to talk about that today because it take up another hour and a half. But that would be my dream, is that, we just make sure that the right programs get to the right people and are not these unfortunate, I see this a lot of times, someone has a great idea, they do a pilot, the pilot ends, that was great, and nothing else happens. And I hate to see that kind of cycle happen over and over again, because even the pilot did the best job ever, it doesn't necessarily get carried forward and expanded the way that it should, because it's helping the people that it needs to reach.
I'll jump in here and just very briefly say, I think I've already sort of laid out what what I think the ideal situation would be, but I would like to just sort of harp on it a minute or two more, and I think we're beginning to see this. So, when and to the point that Dr. Peggs made as well, a lot of this begins with the training that we provide the training that providers and physicians receive, and getting them to see and to understand more fully what actually impacts the health outcomes of patients, and particularly our senior patients. So fully understanding the role that housing or inadequate housing plays in that. In our system, for example, and like every other health system around the country, we track readmissions within 30 days. If we have folks who are readmitted within 30 days, it's not because the person doesn't want to be healthy. It's not because they don't want to do the right things. Oftentimes it's because there are barriers in place that prevent them from doing the things that they need to do. And the last point I'll make is, there was one of the questions I think that we were going to talk about, but we may not have time to talk about, is the adoption of value-based care models, moving away from the fee-for-service models that a lot of us still are dealing with. I think the more we get to the place where, again, and I don't mean to put all of the onus on physicians and providers, but the more we get to the place where we actually link the care we provide with patients, the care we provide to patients, we begin to link that with, to link that even more with the health outcomes that we expect, and we begin to sort of, we have systems where you're either incentivized or you're penalized based upon those outcomes. I think people will pay greater attention to this. I think folks will, unfortunately, sometimes it takes these types of programs to push and drive people to do what we know is the right thing. But when you begin to attach dollar signs to it and you begin to incentivize or penalize based upon health outcomes, people tend to listen a lot greater then.
Great. Well, I think we've only got a few minutes, and I don't want to leave us on a downer. I do want to ask one question of all of you, because it's a question that came up a few times in the Q&A, which has to do with how do we deal with the homeless population. Dr. Peggs, you talked a little bit about this, and Terry, there ain't nothing you can do, I don't think, for a homeless person at this point in terms of modifying something that they don't have. But just to let you know that across the country, the fastest growing group of homeless are older people. And this has a potential of escalating over the next number of years as the aging of the population really ramps up. So just some very quick thoughts, and then we're going to go back to Dwayne to wrap us up. So any very quick thoughts about how you're dealing with the homeless population or what you see in the future?
Sure. So I mentioned we had started this like a transitional housing program that we're expanding across the state. It's going to unfortunately be in the major population areas. So our next move is going to be to Memphis. And then we've been looking at East Tennessee for a while for an ideal place. But we have, you're right, that is an issue that comes up fairly often in the Choices program. Housing, either they can no longer live there, they can no longer afford it. It's been condemned. I've had houses with holes with no roof. So it's definitely something that's on our radar. And like I said before, we have a team that if there's somebody that comes across that is in that situation, we have, we use the legal aspects of things. We can temporarily move people. I'm actually involved with CREA when these issues come up, and then we can help. We do. So it's definitely something that we're concerned about, and you're absolutely right that it's an ongoing issue, but we at least have some things in place to make transitional housing a possibility, and we're trying to expand that so that it's available to more people across the state.
All right, well, I think I better turn it over to Dwayne before we all go out of Zoom. Thank you all. This was fantastic. I was so happy to meet all of you, and I got more in my network now, and hopefully everybody else does as well. So let's have this as the beginning of the conversation and not the end.
That was amazing. So panelists and Dr. Stone, thank you so very much for an incredibly rich and robust conversation. A few takeaways. First, at Memphis Habitat, we see a lot of the similarities and challenges as Terry pointed out at Westminster. One of our big issues is that so many of the seniors' homes here in Memphis actually need a roof. And we believe that we have to get the home in the dry in order to minimize other issues such as mold, which we know can create respiratory issues and problems for seniors. So that's just a personal decision that we've made. And it certainly does increase the cost per intervention to more around $10,000 to $13,000. So that's where we are here. I always hear a lot of talk about person-centered interventions. That's extremely important and imperative for holistic impact on the seniors' overall health and well-being. I heard the point that our healthcare systems don't pay for aging in place, yet they are a beneficiary, and that is true, and really at the crux of what we are talking about here. And that financial incentives are misaligned, and that success lies in combining models and incentives. So we should dig into that. Dr. Pegg said that keeping people in their homes is some of the best medicine. We've heard that many times from like Dr. Megan Sandell. So wouldn't it be amazing if gerontologists like Dr. Peggs could just prescribe home improvements for seniors to address health-related issues that could, be mitigated via improved living conditions? That's what we'd love to see happen. Dr. Mosley pointed out that there is a general reluctance for hospital systems around housing since this particular intervention is not in their wheelhouse, and we absolutely get that, even though it's acknowledged as a social determinant of health. But this is exactly why partnerships between health and housing sectors is vitally important and what we want to work on, because both are consequential to the senior's overall well-being and holistic person-centered health mitigation. My hope and desire really is that, as we are studying the social determinants of health, both from the healthcare vantage point as well as the housing sector, that we also make the decision to address these items regardless of existing regulations and complexities. First, there needs to be a will to do the work, since we know the significant impact that it has on our senior population. And so that's where we want to push and drive the needle in the future, hopefully in the very near future. So Dr. Stone, again, thank you. Our panelists, thank you for your time and efforts to address these issues. Attendees, thank you for joining us today. I hope to see you again tomorrow. Again, we have 3 sessions this week rather than 2. So we hope to see you tomorrow at 10:30 Central, when we'll discuss how hospital systems use social determinants of health to create value-based care. As always, you'll receive an email by the end of this week with access to this week's videos, presentations, and links to the resources we discussed here. So thank you all. Good to see you, and have a wonderful afternoon.
Thank you. Take care.
Thank you.